pre-implantation genetic testing can be done for a variety of cases. You can have it if you have a specific genetic defect, so either a structural rearrangement or something like cystic fibrosis, and you can test your embryos to test for that genetic disease, and you can then ensure if you have a embryo that is not affected with that disease or structural rearrangement, you know that you can have a child, potentially have a child without that genetic defect. And for those patients that need it, they should absolutely have it, 100%. The other arm of pre-implantation genetic testing is looking at aneuploidy within the embryo. So that's looking at the chromosomes and making sure that you have 46 chromosomes and they're all in the right shape. It's currently red lighted by the HFEA, and some clinics will offer it and others won't. Again, it should be applied not across the spectrum like it tends to be in other countries. America is quite heavy on the PGTA front. My opinion is it should be applied for patients who specifically need it. So either recurrent miscarriage, I think something like 65% of miscarriages in the first 6 weeks are due to genetic abnormalities. So if you have recurrent miscarriage, then yes, you should be considering it. The other way that you might look at it is if you don't have that many embryos to choose from, the cost-benefit ratio is wrong. It would just be cheaper for you to have an embryo transfer. If you have a lot of embryos to pick from, that's when I might be tempted to use it, simply because you're almost adding a cheat to the system. If you've got, for example, 10 blastocysts, instead of having 10 transfers and the cost of 10 transfers, you could apply PGTA, see which ones are chromosomally normal, and then you would be cheaper in the long run and also speed up your time to conception. So again, it could be used in that scenario, but not across the board, and certainly again on patient specific based on their clinical history and how their embryos are in the lab.